Welcome back to Pulmocrit Care 2024. We will now proceed with the second symposium planned for today on ventilator-associated pneumonia and nosocomial respiratory infections, a case-based discussion. As moderator of Symposium 2, I invite to the stage Dr. Varuni Samaranayaka, consultant intensivist at the Colombo South Teaching Hospital. Over to you, madam.
Thank you very much. Good morning to everyone. Can I kindly invite our speakers for this symposium today? Dr. Mahen Kotalawala, consultant clinical microbiologist from NHSL. Dr. M. Adhavan, consultant respiratory physician from Teaching Hospital Jaffna. And Dr. Amanda Ranavira, acting consultant intensivist from Colombo North Teaching Hospital. Yeah, so let's start with the case scenario. There is a 46-year-old female patient getting admitted to surgical casualty ward. Her complaints are severe epigastric pain radiating to right side shoulder over 2 days associated with nausea, vomiting and mild fever. She has hyperlipidemia on statins and her BMI is 28 kilograms per square meter. She was diagnosed to have gallstone-related acute severe cholecystitis, which is uncomplicated. So this is the patient in front of us. So she was started on intravenous metronidazole and cefotaxime and carried out the usual management for uncomplicated cholecystitis. She has a bit of a difficulty in getting peripheral venous access. So they had to try multiple times. So her initial fever subsided on day 1 of hospital admission, and over the next 3 days her initial symptoms subsided and she showed some improvement. And the tentative plan from the surgical team was to discharge on oral antibiotics. Unfortunately, from day 4 onwards, patient started developing a new fever. She became tachypnic, dyspneic. And by day 5, she had a productive cough with coarse crepitations on the right lung base. Cardiovascularly, she was stable apart from a sinus tachycardia. So the surgical team wanted to get the chest x-ray done. They were clever. So which showed the right lower zone haziness. And the house officer was smart enough to do the blood gas as well, which showed a PaO2 was 65, which shows a oxygenation impairment. And she was started on 6 liters of oxygen per minute. So these are the investigations from day 1 to and on day 5. So you can see there is a rising WBC count and there is an elevation of CRP. So they were vigilant. A patient who was about to discharge now getting deteriorated. So patient was referred to the microbiologist, respiratory physician and critical care outreach team as well. Right. Can I ask from Dr. Adhavan, what are the differential diagnoses and the probable most diagnosis in this patient with the given clinical scenario?
Thank you so much. So before I discuss the differential diagnosis and probable diagnosis for this patient, I will discuss, next slide please. So I will discuss about the possible reasons for the respiratory decline in a patient who is hospitalized for another reason. So these are the common reasons for so this is one of the common reasons why a respiratory opinion is out for patients who are hospitalized for another reason. Worsening respiratory status. So the worsening respiratory status could be due to a number of reasons. The common things are exacerbation of an underlying structural airway disease. It could be either COPD or asthma. Hospital-acquired pneumonia, which is particularly more common in patients who underwent thoracic or upper abdominal surgeries and people with reduced level of consciousness due to neurosurgical or neurological problems like traumatic brain injury, hemorrhagic or ischemic strokes, and metabolic encephalopathies. And it is also more common in patients who are admitted with chest trauma. And then again, the acute myocardial infarctions leading to cardiogenic pulmonary edema and an undiagnosed heart failure with preserved ejection fraction or reduced ejection fraction can decompensate during the hospital stay. The pulmonary embolism is again more common in patients who are hospitalized. It is because of a number of reasons. The first thing is they are relatively immobilized than at being at home. And also the infections, the procoagulant status associated with infections increase the risk of developing the pulmonary embolism. Others include the ARDS due to a non-pulmonary or pulmonary causes like chest pulmonary contusions, acute pancreatitis, etc. Atelectasis, which could be secondary to the hypostasis or mucus plugging. Not to forget the COVID-19, though they present at the viral replication phase in the initially, which with other symptoms like confusions, undifferentiated fever, but during the stay they can develop COVID pneumonia, and which can cause the decline in the respiratory status. Also the pleural effusions secondary to the abdominal pathology, and in patients who presents with long bone fractures, it can be complicated with fat embolism, which can lead to acute respiratory decline. Next slide, please.
Yeah, so you have given an overview of the possible, all the causes that we have to think in the hospital admitted patients. So what is the likely diagnosis that you can come to in this patient?
So for this patient, the differential diagnosis could be, so you can clearly see a right lobe infiltrate, which is non-homogeneous air space consolidation, which is very suggestive of a pneumonia. The other differential diagnosis could be occasionally a pulmonary infarct can mimic like this. So a pulmonary embolism and a pulmonary infarct is another possibility. The third thing is this patient has an abdominal pathology, cholecystitis. If it is complicated with sepsis, then you can have a pleural effusion. But in this case, you can clearly see the costophrenic angle. But if it is an encysted effusion, sometimes you can still, where posterior located encysted effusion can mimic like a consolidation. So these are the differential diagnoses in patient. So
Go on.
Yeah. So establishing a diagnosis in a patient who presents with a respiratory decline could be made with the help of a clinical history, examinations, radiological investigations like chest radiography, lung ultrasound scan, and CT pulmonary angiogram, and also the laboratory markers like inflammatory markers, full blood count, CRP, procalcitonin. So those CRP, though it's considered as a sensitive marker, so it usually rise within a few hours after the peak of the infections, but the levels peaks at 48 hours. So the initial values may be false. It's not so high at the beginning, but it skyrockets on the following days. And the D dimer, though it is considered as a good marker to rule out pulmonary embolism in patients who present to the hospital with symptoms of pulmonary embolism, in hospitalized patient, the chances of it to be negative is low. Therefore, it is not recommended. And NT-proBNP, again, it's a non-specific marker, but it has a very good sensitivity in ruling out a cardiogenic pulmonary edema. So next slide.
I think in this patient, it's quite straightforward because pulmonary embolism is unlikely. She was cardiovascularly stable and she was given DVT prophylaxis. And also, so I think it's clear. So do you want to talk more about the investigations that you want
I think it is important to discuss about the utility after the lung ultrasound scan. So the first thing is it is easily available at the point of care, and the patient doesn't need to be transported to the radiology department, and it avoids the exposure to ionizing radiations. Therefore, it is particularly useful in pregnant mothers and young children. And the FAST protocol, the blue protocol, which was innovated by the Daniel Lichtenstein, provides as a accurate diagnosis at the bedside with nearly 90% certainty. So it's quite a fast protocol, which was so when the lung ultrasound scan is compared with the chest radiography, it is more sensitive and specific with regard to the evaluation of acute respiratory failure. There are different radiological profiles which would be useful in the diagnosis of the conditions. There are various radiological profiles which are useful in the diagnosis. So one thing is that, we call it an inflammatory type and non-inflammatory type of alveolar interstitial pattern. So if you see a non-inflammatory type of alveolar pattern, interstitial pattern, that is more common with pulmonary edema, but in inflammatory type of alveolar interstitial pattern that you can see in pulmonary infarct, pneumonia, and then you can see the B lines with diminished pleural sliding, shred signs. So those are the radiological markers of pneumonia, which are quite useful at the bedsides to make the diagnosis. And then again, the CTPA, apart from excluding the diagnosis of a pulmonary embolism, the parenchymal window is extremely helpful for us to differentiate it from the other etiologies. So on the image on the left-hand side top, you can see a pulmonary edema where you can see. So here you can see the interlobular septal thickening and ground glass in the bat wing distribution with bilateral pleural effusion. This is highly characteristic for pulmonary edema. The image here, you can see a peripheral subpleural ground glass, which is commonly seen with COVID pneumonia. The image here, you can see a ground glass opacification with a dependent density gradient with relatively sparing the non-dependent anterior lung with dense consolidation in the most dependent part, which is very suggestive of ARDS. So the parenchymal window, so CTPA is much more sensitive than the lung ultrasound scan and chest radiography in patients who have acute respiratory decline. But only problem is because of the resource limitations, we cannot perform CTPA in each and every patient who have respiratory decline.
So that means it solely depends on the clinical scenario, so you have to wisely select the investigations that you are going to select. Right, okay. So the possible diagnosis is hospital-acquired pneumonia in this patient. Dr. Mahen, how do you confirm the diagnosis of this nosocomial pneumonia or the HAP?
Yes, thank you very much for giving me this opportunity. So generally, diagnosis of hospital-acquired pneumonia involve two parameters. So that is, you have to consider the clinical history as well as supplemented by laboratory parameters. So here you can see that diagnosis of hospital-acquired pneumonia, the most important feature or most important parameter we take as important is timing of onset of symptoms. So it has to be developed at least 48 hours after the hospitalization. So that is the most important parameter that we are to delineate community-acquired pneumonia from hospital-acquired pneumonia. So generally, you have to have the disease onset after admission to the hospital, not incubating or not symptomatic at the time of hospital admission. So then it has to have compatible symptoms of pneumonia. So Dr. Adavan very correctly described all the symptoms of pneumonia. In addition to that, these people with hospital-acquired pneumonia can have symptoms of sepsis. So that is not essential to make the diagnosis of hospital-acquired pneumonia. And the other important aspect is clinical imaging. So there has to be evidence of new onset chest infiltrate. So with these three, timing, compatible symptoms and chest imaging, you can clearly diagnose hospital-acquired pneumonia, and it can be supported well with the laboratory test. So laboratory tests are not essential to make the diagnosis. So in this patient, so what is the workup that we are going to do? So the workup has two folds. First is investigation to identify the source. So this is common to any infection. So you have to find out the source of infection. For that, we can do bacteriological investigations and targeted imaging. So bacteriological investigations with targeted imaging, we call it sepsis screening. Mostly we use the term sepsis screening loosely to identify all the microbiological tests. Actually, the term sepsis screening should be limited to appropriate bacteriological investigations and targeted imaging. And then we can do the other set of investigations, so that is to monitor how we have managed the source, how we have come across overcoming the infection of this patient. For that, we can use inflammatory markers. Again, Dr. Adavan in his presentation, he has mentioned about all the inflammatory markers. And again, you can go for imaging, that is to assess how we are fared with the source management. So in this way you can do. When we discuss on the microbiological investigations, again you have three types of investigations. One is pulmonary samples, the second one is blood investigation, blood culture, and third one is tissue diagnosis, that is the histology. So generally for hospital-acquired pneumonias, we depend on non-invasive pulmonary samples. For that, we need sputum. So generally, the sputum, although it is a good sample, it has certain defects, because nearly 50% of the people who are in the hospital, they can't produce a good quality sputum sample. So when you don't produce a good quality sputum sample, you will end up in a poor quality microbiological investigations. So that is the reason, that is the most important reason for you to get most of Klebsiella pneumonia isolate from sputum samples. That is due to prior antibiotic therapy as well as poor quality of the sample. Then you have the other type of non-invasive samples, that is which is known as mini Barlow blind lavage. But unfortunately in this patient, in this state, you can't go for blind lavage. So then the invasive sampling, again for this patient, it is not that much of recommended. So you can go for this PS, protective surface brushings, and bronchoalveolar lavage, transtracheal aspirates, and all other things. In addition to that, I would recommend blood cultures of this patient. So when you are going for blood cultures, the basic principle is you have to take more than 2 cultures. So single culture is equal to none. So it is not significant. So therefore, my message as a microbiologist to you all who are involving in patients with pulmonary infection, if you are going for a blood culture, take 2 blood cultures. If the patient's condition is worse, if the patient is likely to die within next 24 hours, so you can take 2 blood cultures from 2 different sites and start treatment. So don't send us single blood culture. And the other thing is the tissue diagnosis, which may not be applicable for this patient. Tracheal secretions often reflect. So now these tracheal secretions, the thing that we do, so generally that is not a good sample and it reflects upper airway contaminants. So that is why you are ending up with the most of these resistant flora in your microbiological samples. Another thing is, if you don't grow anything, if you don't get anything from your sample, don't think that it is cleared. Sometimes it could be some laboratory error or processing error or any other error associated with the sampling method.
Yeah. Dr. Amanda, can I ask, what are the risk factors which are leading to hospital-acquired pneumonia?
Thanks, Dr. Varuni. There are multiple risk factors for the development of hospital-acquired pneumonia, such as underlying medical conditions like chronic respiratory disease, renal illness, and obesity, weakened immunity, malignancies, invasive procedures such as upper abdominal and thoracic surgery, prolonged length of stay in the hospital, prior antibiotic use, non-invasive ventilation, as well as smoking, malnutrition, aspiration, and depressed level of consciousness, which in turn lead to aspiration. The risk factors that we identified in our particular patients were obesity and prolonged length of stay, as well as prior antibiotic use.
Yeah, exactly. Can I ask Dr. Mahen, what are the principles in managing hospital-acquired pneumonia in this kind of a patient?
So this is the basic grid line that I have come up with when you are treating any infection, not only to hospital-acquired infection. So this is common to any infection. Empiric antimicrobial selection. So if the patient is bad, so you can go for empiric antimicrobial therapy. So once you gone for empiric antibiotic therapy, so you have to follow it up with a de-escalation with the availability of microbiology or other lab test. So empiric antimicrobial therapy, generally you decide with your cumulative antibiograms, which will be supplied to you by the microbiology departments of your hospitals. The other principle is optimization of the duration. So that is when to stop antimicrobial. So we know we are a civilization or a group of people who are dependent on antibiotics. Our culture is antibiotic. Everybody requests antibiotics. So therefore, it is very important to optimize the duration, right? So that is another principle that we have. Another thing is regular reviews and multidisciplinary team meetings. So that's a very important thing that we are usually ignoring this fact. So even if you are treating the patient, so you have to keep on reviewing the patient's need for antibiotics, whether your antibiotics are working or not. Likewise, that you have to keep on reviewing. So those are the treatment principles.
Thank you very much for highlighting those important basic principles in deciding on treatments. Yeah, for this patient, considering all the factors, what is the antibiotic of choice that you will select, Dr. Mahen?
So now, considering the patient's diagnosis, hospital-acquired pneumonia, it seems to be like uncomplicated. Patient is not having any evidence of decompensated sepsis. So in that way, we can go for this traditional escalatory care. So as a first choice, I would go for IV piperacillin tazobactam, which is a broad spectrum anti-pseudomonal antibiotic. So that will provide a good coverage for the most of the organisms which causing hospital acquired pneumonias in our setting.
Okay, thank you. What are the other important aspects in managing hospital-acquired pneumonia, Dr. Amanda?
Thanks, Dr. Varuni. Next slide, please. Now that we have started on the antibiotics, I would focus on the oxygen therapy and supportive care. For this patient, we would target a saturation of 92 to 96%. And if the patient is a chronic carbon dioxide retainer, we would go for a lower saturation target of 88.
But she was not, isn't it?
Yeah, she was not. This is not the case of this patient. And when considering starting oxygen therapy in the ward setup, we would use conventional oxygen delivery devices like Venturi, nasal prongs, and oxygen Hudson mask. The nasal prongs and Hudson mask, they are variable performance oxygen delivery devices where the delivered FiO2 is dependent on the patient's inspiratory effort. On the other hand, Venturi is a fixed performance device where the inspired oxygen concentration is independent on the patient's inspiratory effort. We have to make sure that we give the recommended flow per a particular Venturi device to a patient. Sometimes it is mentioned on the Venturi device because without that we would not get the desired oxygen concentration. As an example, if you want to give 40% oxygen, then the flow rate should be 10 liters per minute. Failing that, we will think about escalating the patient to high flow nasal oxygen whenever it is available in the ward setup. However, what I wanted to emphasize is that we need to identify the deteriorating patient early rather than keep on escalating, and we have to flag this patient if he is deteriorating to the critical care outreach team before it's too late.
So they did it, isn't it, at the very beginning?
They did it. So this is not a forum to discuss about the early warning score. However, I would like to highlight the importance of the early warning score.
Yes, please.
It's just the basic physiological parameters, about 7 physiological parameters that we would monitor in most of our hospitalized patients. And it's a track and trigger system where the score is given to a deviation from the norm, and deterioration of the physiological parameters would escalate escalated response. So if the patient is in the yellow zone, that requires urgent clinical review, and when the patient moves to the red zone, that triggers a med call as well as critical care outreach review, whatever is available. And if you look at the trends as well, so if you can move on to the next slide, please. So this is the red zone, which triggers the med call or urgent review by the critical care outreach team. This is the tracking of observation. You will see the trend, and then you can actually predict the trajectory of the patient and see that the patient is not heading towards the correct direction. It's really important to identify them early, be vigilant, and refer them early before it's too late. This is available in few hospitals in Sri Lanka, and it is nationally recommended as well. Implementation is sometimes an issue. However, in countries where this is being regularly used at national level, this has shown to save thousands of lives each year.
Thank you, Amanda. Ardhavan, what are the other concerns when managing a patient with hospital-acquired pneumonia from your point of view?
So next slide, please.
Yeah.
So generally, when we start on empirical antibiotic therapy, the most of the patients makes a clinical recovery, but occasionally the patient doesn't show a clinical improvement. So it could be because of a non-responding nature of the pneumonia, which needs to be evaluated with invasive microbiological sampling, etc. So I'm not going to discuss about that in detail. But in addition to the non-responding nature of the pneumonia, we also need to, when they are declining from the respiratory point of view, we need to think about the possibility of a mixed pathology contributing to that decline. For example, in a patient with hospital-acquired pneumonia, there could be a secondary ARD, secondary to HAP, or it could be due to another non-pulmonary pathology. Then again, the decompensation of the heart failure with preserved ejection fraction or reduced ejection fraction can lead to superadded pulmonary edema, in which case the fluid restrictions and diuretics may be essentials. So this could be made, the diagnosis could be made with the help of the radiological imaging, lung ultrasound scan, and the NT-proBNP with the biomarker. Also, the patients with bacterial pneumonias are prone to development of exacerbation of underlying airway disease. So this can lead to increased work of breathing and increase in the oxygen saturation that needs to be appropriately managed with bronchodilators, steroids, etc. Then again, as I mentioned before, the infection itself is a procoagulant factor which increases the risk of pulmonary embolism, and also the immobilizations contribute to the risk of pulmonary embolism. That needs to be suspected. If the sepsis is improving, the patient's oxygen requirement is increasing, we need to think about the possibility of a pulmonary embolism, and appropriately the patient needs to be appropriately investigated. Also, if the pneumonia is not responding, we need to remember the possibility of a complicated parapneumonic effusion and empyema that could be easily detected at the bedside by the lung ultrasound scan, and the pleural effusion needs to be drained to improve the outcome of the pneumonia.
Thank you, Adwan. So what happened to the patient? Patient was managed in the ward as for hospital-acquired pneumonia and started IV piperacillin tazobactam and given oxygen therapy. Maximum required was 60% Venturi, and initial investigations basically came to the baseline, and patient was discharged on day 14 of hospital stay after treating with IV antibiotics for 7 days with a tentative plan of interval laparoscopic cholecystectomy. Right. So the same patient comes after 3 months for the planned surgery. Unfortunately, she had an intraoperative complication. There was an inadvertent cystic artery damage which required laparoscopic surgery converting to open surgery. And she had a blood loss of about 400 milliliters, but since pre-op hemoglobin was all right, she didn't require blood transfusion intraoperatively. Total duration was 5 hours, and she was unable to extubate, unfortunately, towards the latter part of the day when the surgery was done because of the mixed acidosis. So she was intraoperatively given at the induction the double dose of IV cefuroxime, and intraoperatively, since 3 hours were gone, she got another dose of cefuroxime. Unfortunately, things were not in the right direction. She was unable to extubate safely over the next 2 days due to the development of ileus, inadequate respiratory drive, and the delayed recovery from the sedation. Somehow, ileus got gradually resolved. So by day 3, patient developed a high fever, deteriorated with type 1 respiratory failure with new onset chest x-ray findings. She was producing thick mucopurulent secretions from the endotracheal tube. Her ventilatory settings went up, PEEP went up, FiO2 went up, and she required noradrenaline to maintain mean arterial pressure of 65 despite of safe fluid resuscitation. This is her x-ray. Do you want to comment about that, Adwan?
So on this chest X-ray, the patient is being intubated. So I cannot able to comment about it because the bottom of the X-ray is not clearly visible. But what we can clearly see is there is bilateral air space opacification of mixed density, predominantly of a ground glass density. So this picture is possible with pulmonary edema, ARDS, or even viral or COVID pneumonia. But in this context, in the patient with increased purulent secretion, rising CRP, and is hospitalized, I would more think about the possibility of a ventilator-associated pneumonia.
Yeah. So as you can see, her WBC count went up and the CRP also went up with the time. So you clearly mentioned the differential diagnosis that we have to think of, isn't it? ARDS, ventilator-associated pneumonia, pulmonary edema, fluid overload aspiration. What do you think the probable diagnosis is?
So the likely diagnosis, considering the picture, it is ventilator-associated pneumonia.
Okay.
It is early onset ventilator-associated pneumonia.
Okay. Thank you, Adwan. Dr. Mahen, how do you define ventilator-associated pneumonia?
So this is a very interesting definition, right? So now ventilator-associated pneumonia, so you have to think of whole picture. So now Dr. Adwan very clearly said there are the possibilities of all lung involving pathologies. So now generally when we have a patient coming with some sort of a clinical abnormality associated with lung functions, admitting to ICU with ventilation, so you have to think of that incidence as a ventilator associated event. So that can include non-infective as well as infective insult. So generally that is what mentioned by ventilator-associated event. And ventilator-associated condition is also very much similar to ventilator-associated event. So you can consider both together. Here you can see the ventilator-associated condition. So you have to have more than 2 calendar days of stable and decreasing daily minimum PEEP. That's a definition for that ventilator-associated condition. Right. So then you have the next one, the ventilator-associated complication due to a probable infection. So the infective complication that includes ventilator-associated pneumonia as well as ventilator-associated tracheobronchitis. Both insults are included in IVAC. So we have to go for the next one. So that is the ventilator-associated pneumonia. So again, ventilator-associated pneumonia has two segments. One is possible pneumonia and probable pneumonia. So if you have the scale to differentiate possible pneumonia from probable pneumonia, I would say possible pneumonia have slightly lesser significance, and the probable pneumonia would be the more basic. For practical purposes, we can say pneumonia that develops in a patient who has been on mechanical ventilation for more than 48 hours. So that is as a ventilator-associated pneumonia. So that itself is enough to initiate treatment protocols.
Thank you, Dr. Mahen. Amanda, what are the risk factors for developing VAP, and was our patient in increased risk?
Yeah, so similar to the risk factors for HAP, there are multiple risk factors for VAP as well, such as increasing age, chronic lung disease, malnutrition, renal failure, anemia, chest or upper abdominal surgery, polytrauma patients, aspiration and previous antibiotic therapy, especially broad spectrum antibiotics, reintubation, frequent ventilator circuit change, as well as prolonged muscle paralysis. The risk factors that we identified for our patient were upper abdominal surgery, possible aspiration in the context of ileus that she developed post-surgery.
And laparoscopic surgery.
Yeah, laparoscopic surgery, converted to laparotomy, and previous antibiotic therapy. She was on broad spectrum antibiotics as well.
Yeah. Dr. Mahen, how do you diagnose VAP?
Yeah, very much similar to HAP. So generally VAP is considered as a subset of hospital-acquired pneumonia. Go ahead. So here, and again, the diagnostic principle same as HAP. So you have to think of the timing, the compatible symptoms, chest imaging, and laboratory diagnosis. So we have already discussed. And when we are discussing about the HAP, we have discussed about the non-invasive sampling. And now for the hospital ventilator-associated pneumonias, we prefer invasive sampling. And again, if you don't have any sort of this thing, you can go for blind lavage, as we have discussed earlier. Bronchoalveolar lavage, protective surface brushings, transtracheal aspirates are the things that we prefer, but unfortunately because of the workload, so we won't be able to do it on each and every patient. Never to forget blood cultures. Again, same principle, at least two blood cultures from a patient.
Okay. And what are the common pathogens in ventilator-associated pneumonia, and how do you decide on the antibiotics?
Yeah, so first we'll look at the common pathogens. Here, this table shows you the common most organisms which causing ventilator-associated pneumonias. Here you can see basically gram-negatives predominate. It is Acinetobacter, Pseudomonas, coliforms, that is Klebsiella pneumonia and E. coli and other groups. In addition to that, you will be having some small proportion of enterococci and maybe around 10 to 15% of MRSAs. But in our setting, it is basically a gram-negative problem, Acinetobacter, Pseudomonas and coliforms. Okay. So again, you have to make sure that when you are sampling, you have to provide the proper and the correct sampling technique in order to get a good result. So here, interesting finding, so that is NHS-cell isolates. Here it's very much compatible with the worldwide data. So we see a lot of coliforms, Pseudomonas and Acinetobacters, and so this is 2 months, 2024 April and 2024 March. So it's very much going in hand with the worldwide data. Pseudomonas, Acinetobacter and coliforms constitute around 80 to 90% of our isolates.
So how do you decide on the antibiotic therapy in
Yeah.
VAP?
Okay, same principles. Principles of antibiotic therapy, irrespective of the syndrome, it's same for all patients. So again, so you have to think of few things, clinical presentations. So that is if the patient is having a mild pneumonia or pneumonia with sepsis or pneumonia with septic shock. So that will decide what is the coverage and what type of coverage you require for the management. Again, you have to think of local epidemiology. So the degree of multi-drug resistant, extended drug resistant and pan-drug resistant prevalence in your hospital. Another thing is the empiric guidelines. So what are the empiric guidelines available in your hospital or the country? All these factors will determine the empiric treatment. So generally, if you go only by the empiric guidelines, most often you will fail because you have to follow it, the empiric guidelines with the microbiology inputs. And in addition to that, I would like to show you this disastrous local epidemiology in our setting. You can see the blood culture isolates of gram negatives. So the red color means you can't use that drug. Green color means you can use it. Yellow is in between. So you can see the amount of reds in the this thing. So this is a disastrous epidemiology. So most of the time you don't have any treatment to treat. So this is what we are dealing in local setting. So, and in addition to that, so we have to have a framework of designing the timing and broadness of initial antibiotics. So, at what time should you start and what is the level of coverage that you are going to give. So, anyway, sepsis is considered as a bidimensional disease. It has two dimensions. One is the infective etiology. The second one is probability of death, that is the clinical severity. So, when you are treating a patient, you have to think of both axes, not only one etiological agent, but you have to think of the clinical presentation as well. This framework given by the Prescott et al., so one of the chest physicians, critical care chest physician, so she has very clearly mentioned the timing and broadness of treatment. So according to this framework, there are 4 quadrants. So this quadrant and this one. So upper quadrants are clinically severe and this is not likely to be due to infection, this is likely to be infection. So irrespective of this is infective or non-infective, if the patient's condition is very bad, you have to consider that this is likely to be due to infection and sepsis and septic shock, you have to start. As Dr. Geetal very correctly said during his presentation, you have to use whatever the resources to whack the situation to safeguard, salvage the life. But when you are coming across some patients where you have time, you can always try to follow it up with microbiology investigations, the traditional escalatory care. So this framework is very good to decide on antibiotic timing and the deciding on the broadness of coverage.
Okay, thank you for highlighting that, Dr. Mahen. Adavan, considering all the factors, what is your antimicrobial prescription for this patient? I think Adavan and Dr. Mahen both can.
So I will always liaise with the microbiology team in making a decision on.
Thank you very much.
Okay, so if it is my ICU, so we don't have, unfortunately, we don't have a local microbiology data or local antibiogram. So in my based on my experience, based on what I see in a regular basis, so 2 common pathogens, as Dr. Mahen mentioned in his lecture. So 2 common pathogens are gram-negative coliform pathogens. We cannot differentiate whether it's a Klebsiella or other pathogens. And the second one is Acinetobacter. So most of these pathogens are XTR and they are frequently only sensitive to colistin. Unfortunately, we don't have the DIS for ceftazidime, avibactam or other later generation combination antibiotics. So, however, now we are aware that the ceftazidime avibactam is available in the private pharmacies. So if I have all the resources available, my empirical antibiotics, if the microbiologist agrees, would be a combination of ceftazidime avibactam with polymyxin.
Dr. Mahen, will you agree?
So generally. Our phenotype is we don't agree with anybody.
Okay.
So we have our own vision and this thing. But I agree with giving starting colistin because that will cover Acinetobacter and Pseudomonas as well. But not ceftazidime avibactam, because for ceftazidime avibactam to start, you have to have firm establishment of its etiological agents. So without the proper microbiology backup to say that this organism will be effective against Ceftazidime avibactam, we are not in a position to use it as an empiric agent. But I would say, I would agree with you, Dr. Adhavan, if you suggested carbapenem with colistin. So that would be a good something, some common stage that we both can agree. And always, because you are worrying about Acinetobacter, too much of Acinetobacter, which I also agree with that, I would consider colistin with tigecycline or minocycline, something like that, for this patient, considering the patient's need for urgent, rapid recovery.
Okay, thank you. And the duration of antibiotics, how you design?
So that's a very tricky question. So
But practically we face day in and out.
So
isn't it?
duration of
Yeah.
antibiotics. So there is no specific time period mentioned. So if you like, you can give long term. If you like, you can give short term. So we have to come into a balance. We have to trade off between the risk of antibiotics and the risk of illness. So here is a good guide that I have mentioned. So it shows the relative risk of the issue as well as duration of antibiotics. So you can see the purple line. So that is the relative risk for life due to illness. And the second one, the red line, is relative risk of antibiotics for the patient. So with the point where they cross, that you can decide on to stop antibiotic.
Okay, thank you.
And again, when you are using antibiotics, so you have to find out what is the purpose of giving antibiotics. Remember, antibiotics are given to kill microbes. It is not to safeguard the healthiness of the patient. So therefore, whenever there is organism, you can start antibiotics. And antibiotics treatment are three folds. One is empiric antibiotic therapy, very transient, for 48 hours till you get micro input. And the second one is the organism directed or targeted therapy. So that is you institute once you identify the etiological agent. Prophylaxis is not applicable to here. Again, empiric therapy, there are two types of empiric therapy. So that is the that is the targeted empiric therapy. For example, if you are managing community-acquired pneumonia, you can target C-penicillin and clarithromycin, or cefotaxime and clarithromycin. So you give empiric therapy, but you target a specific syndrome. And the second one is the salvage. So this is very important concept. If the patient is coming with sepsis and septic shock, so you can't wait. So you have to salvage the life. The other one is again targeted treatment. Again, you can target, and if the patient is having sepsis and septic shock, you forget the targeting and you try to salvage the patient's life. So here, the famous Kumar and Clark graph, you can see time 0 where the septic shock comes, and if you don't apply treatment appropriately, the probability of survival will go down with the time. So after 36 hours of not starting appropriate antibiotic, probability of survival is almost 0%. So therefore, we have to be, when you are treating with antibiotics, there are two things: right appropriate, right time, and broadness of coverage.
Thank you for highlighting all these practical points, Dr. Mahen. Amanda, are there any other important aspects as an intensivist that you will consider when you're managing this patient in the ICU?
Yes, now this patient is on a ventilator, so I would like to go ahead with lung protective ventilatory strategies to minimize the further injury to the lung, targeting plateau pressure of less than 30 water centimeters, and try to deliver tidal volume of about 6 ml per kg of ideal body weight, and bedhead elevation to 30 to 45 degrees in order to prevent aspiration. And we need to take special care when handling the airway equipment as well, hand hygiene when handling the ET tube, use of HME, heat and moisture exchanger, closed suction circuits, and as well as limiting the ventilator circuit change to whenever they are soiled. Appropriate use of gastric ulcer prophylaxis is also important, because the gastric ulcer prophylaxis increases the gastric pH, which is detrimental to the protective effect of the acidic gastric pH. Glycemic control with the target of 100 to 180 milligram per deciliter, neutral to negative fluid balance, not to make the lungs so wet. DVT prophylaxis, kinetic therapy, as well as physiotherapy. The kinetic therapy is a new concept where you rotate the patient to 40 degrees every 2 to 4 hourly, which has shown to reduce the rate of VAP, and it improves the mucociliary clearance as well.
So it's a lot to do with the patient
Yes,
with VAP, isn't it?
of course.
So we don't have to trouble with all these patients if we can prevent? So what
Yeah.
are the preventive measures for VAP that you can recommend?
When talking about the preventive measures, this is where the web bundle comes into play. It's a group of evidence-based interventions which has shown to improve the outcome when implemented together rather than implemented individually. That is why a bundle is, it is called a bundle. There were only 4 elements in the original web bundle: 30-degree head-up tilt, sedation hold, stress ulcer prophylaxis, and oral care. In 2010, 2 further elements were added: subglottic suction and maintaining cuff pressure between 20 to 30. And the aim.
This is the
Yeah, so this is the ET tube with subglottic suction port that we sometimes use when we anticipate prolonged ventilation to our patients. There's a small opening just above the tracheal tube cuff, and a channel goes along the shaft of the ET tube and opens into and then connects into the subglottic suction port. When the secretions pool above the tracheal tube cuff, we can aspirate them via this yellow subglottic suction port, and the recommendation is to aspirate every 4 hourly. This has been shown in randomized control trial to reduce the rate of VAP, duration of mechanical ventilation, as well as duration of ICU length of stay. And yeah.
Yeah. So what are the possible complications that this kind of a patient can get during the ICU stay?
so-
If you can briefly.
So as for any
describe
pneumonia,
us.
so it could be complicated with parapneumonic effusion, which could be complicated, or empyema. So and also it can lead to ARDS or progression of the ARDS. And then especially if the organism is a necrotizing in pneumonia like Klebsiella or Staph aureus, it can lead to pneumothorax and lung abscess formations. As I mentioned before, the exacerbation of airway disease is not uncommon with bacterial infections. And then if the pneumonia is not responding, the patient can progress to severe sepsis and death. And it is important to remember the all-cause mortality of the ventilator-associated pneumonia is approximately 50%, but the attributable mortality is only 13%, and it is estimated to prolong the hospital stay by approximately 7 to 9 days. And prevention of each VAP incidence saves 40 to 50,000 US dollars in USA. So that is one of the important thing that I convey the message to the nurses in the ICU, that if you wash your hands and if you practice barrier nursing, it would save 40 to 50,000 US dollars.
Right. So it was highlighted how bad a patient can do if they get these preventable hospital-acquired pneumonias and ventilator-associated pneumonia, which is a menace, I would say. So now the world is moving forward. What are the new evidence and way forward in managing ventilator-associated pneumonia? I would like to ask Dr. Mahen, are there any aspects that the other end of the world is practicing with regard to managing VAPs, microbiological point of view?
So it's like this. So now it's a establishing etiological diagnosis. Another one is precision medicine, and where you consider not only the etiological agent but the phenotype of the individual host in your arranging the management of patients, and giving antibiotics, the precise antibiotics, the new antibiotics which has different effects from the traditional ones. And when you are managing with severe pan-drug resistant or extended drug resistance, so you can consider of giving something like bacteriophages. But these are very, very high-flown things. Very, very narrow number of patients with less trials were done. But first of all, we have to go for the traditional things that we can do, right? So audits and prevention bundles and optimization of patients before going into surgeries, and prevention of exposure to unnecessary antibiotics, prolonged giving antibiotics, and that sort of thing. But the most of the new things are aimed at diagnosing ventilator-associated pneumonias.
Right. So I think in our setup it is very important to prevent all these hospital-acquired things, because this hospital-acquired pneumonia and the VAP is also comes under hospital-acquired pneumonia. All these are preventable. So do you want to highlight anything, Dr. Mahen, from microbiological point of view? Because this is the most important aspect. Prevention is better than cure, because these patients who get VAP, their morbidity, mortality is very high. They stay in the ICU for longer days. So I don't have to say, I think all of you have witnessed hospital-acquired pneumonias and patients who are on ventilator-associated pneumonia, the cost and how we lose lives. So to highlight on prevention again, because Amanda described certain measures technically we can do once the patient is intubated, but as a whole,
Hand hygiene.
yes, the thing. Thank you
If
for
you ask me
mentioning that.
single thing, I will say hand hygiene.
Right, okay, thank you. Right, so I think the management principles of hospital-acquired pneumonia and VAP were clearly highlighted. But when it comes to practice, y'all are practicing and y'all are working in wards, ICUs. So I would like to give the audience the opportunity to ask the questions that you come day to day to clarify with this expert panel. It's open to you.
This is to Dr. Mahen. First of all, fantastic discussion, fantastic informative talk. Now, you were talking about stopping antibiotics. And do you want to comment about stopping antibiotics or de-escalation? Is there
No.
any difference?
So it's like this. So now, if you remember the grid that I have shown you, it starts with empiric antimicrobials. So that is basically with the antibiogram. You decide on, you identify the syndrome, you identify the syndrome and start on antibiotic on empiric basis. So that generally you are allowed empiric antibiotics or the maximum of 48 to 72 hours. So after that you have to so it's okay, right? So, right? So that is empiric therapy. So then with the lab availability of lab results, so you can de-escalate. So what I meant by the duration, total duration, so both empiric as well as targeted treatment, right? So therefore, in non-invasive pneumonias, actually speaking, you can cut down antibiotics when the procalcitonin level, the initial procalcitonin level drops to 80% of the original value within 4 days. So if the original value is 30, and if after 4 days, if your value is something like 3 or 2, so you can omit antibiotics, or you can streamline, you can give it to, but change it to oral. So our problem is, our system is as such that we are dependent on antibiotics. So one reason for that is our diagnostics are not to the level of your expectation. So we contribute for 90% of the issue. But what happens when generation by generation they depend on antibiotic prescription because you lack the vision of which the pathology is, you tend to compensate it with antibiotics. So now this has gone too far. So now we are very dependent on antibiotics, and we have forgotten, we have all forgotten about the very basics of medicine. So, Osler is the first person who said, you bring the laboratory to bedside. So that was his statement. So what we are doing is, we are sending the laboratory home, and we are sending the laboratory part to private sector to get the profits. And we have curtailed down all the tests. Even in the apex institution like NHSL, we are doing the same repertoire of tests as in a group A or a tier A base hospital. So that is the pathetic situation.
Can I also comment on that? I think you brought up a very interesting point. Now recently I had to do a procalcitonin in a patient who was admitted to the ward. They have charged 13,000 rupees from the patient. But unfortunately, these investigations in a in a limited way should be there, at least in teaching hospitals and high-level hospitals, so that we can save a huge amount of money. Rather than, polymyxin, tigacycline, even simple meropenem, imipenem cost a huge amount of money to the Ministry of Health and the taxpayer. But if these facilities are available, these investigative facilities are available, regarding the microbiological etiologies, the resistant patterns, as well as these simple investigations, we can de-escalate these patients rather quickly and then prevent the unnecessary complications of not only resistance, antibiotic-associated complications. That might be the next problem that the patient might be faced. Maybe a Clostridium difficile infection or, antibiotic-associated problems. So I think it is now up to us, the colleges, the professional colleges, to persuade the ministries to give us these facilities, rather than just even in the Medical Research Institute, which is the prime institute in our country. Sometimes these reference investigations are not available. When the result comes, the patient had already died. So I think this is time that we have to most likely come into play as the colleges to get these changes done, hopefully.
Right.
Sorry.
I'm sure there are a lot of doctors who manage patients with HAP and VAP facing a lot of practical problems. So it's open to you to come up with your questions. I think it's
Yes,
the
I
best
am also a
forum to.
doctor who manages HAP and
Yes,
VAP.
okay. Yes, please, Adhavan. Okay.
Sorry, yeah. So sorry that if I am saying this, the many of the microbiologists in the audience as well as in the panel would be angry with me. I'm sure they will be in disagreement with my opinion. But I have to tell this. So in my view, with regard to the microbiology profile and antimicrobial resistance pattern of HAP and VAP pathogens, have gone to a level which is extremely alarming. And so so the general principle of an empirical antibiotic should be that your empirical antibiotics, if you're treating an infection with an empirical antibiotic, it should cover at least 80% of it's 80 to 90% of the potential pathogens. So that I have several arguments when we are making these presentations with Dr. Mahe.
Yes, I have to kind
So,
of
yes.
sort out,
Yes.
balance everything. Yes.
So that.
But still open to discussion.
So
Yes.
that I agree the quality of the sample is we need to take into account. So that I totally agree with that. But considering all that in mind, I still believe if you take the microbiology profile of any hospitals in Sri Lanka, it would be definitely more than 20% of the bugs are sensitive only to colistin or polymyxin. This is an absolute truth. If we create our own microbiology data, so that I can tell that I see at least 4 to 5 nosocomial pneumonia managed in a weekly basis. So it is. I can be certain that. If you take the whole pathogens and if you create an own microbiology, a national microbiology data and a local antibiogram for HAP and VAP, you would see definitely more than 20%. If you ask me, I would say more than 80%. Definitely more than. So in which case, the colistin needs to be the empirical antibiotics for all the patients with HAP and VAP.
Oh my God. Right. Okay. Microbiologists are there, so you can open up. Yes.
Can I slight deviation
Yes,
from
sir.
the current interesting topic to amend? Now we are managing patients in the ward and HDUs without anesthetic support. We see suddenly we have escalate oxygen when the patient's oxygen requirement goes up. We go by certain parameters like PF ratio or ox index or oxygen number of liters we are giving. And the blood gas analysis also give you something about AA gradient, which may not be much concern. That's right. So what do you recommend as the best way to look for increase in requirement of oxygen in a ward or HDU type patient?
in the ward setup, we usually go ahead with the target saturation 92 to 96%, and usually when the FiO2 concentration goes above 0.4, then we think about escalating to high flow nasal oxygen, or if the patient is showing evidence of respiratory distress, because when we give the high flow, if the patient is breathing with the mouth closed, then we would be delivering some sort of a PEEP as well, like 5 to 7 water centimeters, provided the patient is not a mouth breather. And usually when the high flow settings are also heading towards the wrong direction, like 50%, 50 liters, then I don't think we should be able to manage the patient in the ward. Sometimes people go ahead with the PF ratio as well, mainly with the ARDS, like mild, moderate, severe. Mild would be 200 to 300 mercury millimeters, and moderate 100 to 200, and less than 100 is severe ARDS. But I think for the ward setup and the doctors, basically people go ahead with target saturation. We have to keep in mind whether the patient is a chronic carbon dioxide retainer or not, because as Dr. Adavan mentioned during our presentation, the discussions, in I think in UK, they have two scales, scale 1 and scale 2 oxygen therapy. In the Muse chart, that the early warning score chart, there are two scales, scale 1 and scale 2. Scale 1 is for normal patients with a saturation 92 to 96%. Scale 2 is for patients with chronic lung disease, where we target 88 to 92%. So when you get a patient with chronic lung disease, you just cross off the scale 1 and go ahead with the scale 2. However, the patient, the MED-CAL trigger is saturation less than 82 or saturation more than 97. But these patients, they are likely to deteriorate, so they need to be reviewed, I think, every 6 hourly or 24, then later 24 hourly by a clinician.
Thank you very much, sir, for raising that
Yeah.
question, because we get patients to ICUs after deteriorating and when they are, like, very much ill. So in the ward setup, identifying them is very important. That's why these early warning scoring systems, not only for respiratory patients, for any patient, identifying them early when they start deteriorating, it is very important to practice. So it's at national level developing, but the implementation is the problem.
Yeah.
So a lot of ward people, apart from the specific respiratory wards, if we have, we can give them the the oxygen therapy guidelines and things. But in busy medical surgical ward setups, the house officers and the medical officers cannot handle the workload. So for selected patients that the consultant or the seniors decide these patients need more attention, they can be selectively taken and put on these early warning scoring systems. So it's a topic on itself. So I think that should be the way forward.
Yeah, that's important, because now when we ask for ICU beds, there'll be a lot of politics involved in.
Yeah.
So you need to give us a guideline. Now this is the time that intensive care team should take this patient. No? Otherwise the ward staff gets pushed to the wall and they cannot manage. Another small point is, when the patient's oxygen desaturation is taking place in ICU setup, we were called sometimes to do a urgent bronchoscopy to do bronchial lavages.
Yeah.
Is there evidence, or you have any knowledge about this practice, whether it should be because sometimes we have seen the patients improving.
Yeah. So that solely depends on the clinical scenario. I think if there's a mucus plug and that is a lung collapse, complete whiteout or something like that, and that is the reason for the desaturation. Unless we take the plug out, do bronch, then the patient would not improve. However, in a clinical scenario where there is multifactorial, the multiple factors contributing to the desaturation, I don't think we need to stabilize the patient first and then go ahead with bronch as the second step. I'm not sure about the evidence. I'm so sorry, I don't know whether you should be able to give more insight.
So I was popular among the anesthetists in NHSL when I was a senior registrar of Dr. Amita Fernanda, because I always accept the call of performing the bronchoscopy. I performed probably several bronchoscopy, but my personal view is I killed more patients than provide any benefit to them, because many of the patients who are on, so some of them arrested immediately while I was performing the procedures.
I think that
so
also needs some
actually
guideline.
now Here onwards, I wouldn't perform a bronchoscopy in a patient who had a complete lung collapse, which is presumed to be due to a mucus plug. It's a total whiteout lung which is presumed to be due to mucus plug. In such patient only, I will attempt a bronchoscopy in the future.
Yeah, better to have a guideline again, no? Because I have seen some patients improving.
Yeah,
definitely.
so to add on to that, currently we don't have any bronchoscope at North Colombo Teaching Hospital, and we have a patient who keeps on plugging with the mucus plugs. So unfortunately we don't have the bronchoscope, and I think Valisara also they don't have it these days, unfortunately. So what we do is give aggressive physiotherapy, turn him, and then he recovers, and then again goes into mucus plugging and lung collapse. Unfortunately, we don't have any other way of addressing that issue. However, I have seen some patients with lung collapse improving with aggressive physiotherapy and increasing PEEP. So we do not necessarily need to do that, provided that the patient is not very stable. Yes.
Do we have time? Right. Okay. Yeah.
As you said, in my experience as well, the bronchoscopy, selecting a correct patient, and it's not just one team. If you call the pulmonologist, then probably you have to be with him and stabilize the patient.
Yeah.
But the new trend is it's been done by the intensivists in the ICU, and most of the ICUs in the proper way should have the bronchoscopy, and most of the time in the UK they straight away go and do the bronchoscopy, and most of the time it's very successful, and it's a job of intensivists actually nowadays.
Yes. Ambuscope. No, the ambuscope. Yeah. Uh-huh.
We have these portable bronchoscopes that we had previously, where you had the eyepiece, right? And it's about when in the COVID era we bought it for about 2.5 million rupees. It's not expensive as the other bronchoscopes, and as at least in teaching hospitals, we got one in Rattapura after having the necessary documents prepared. But at least if we can recommend, at least these ICUs have this, and that bronchoscope is situated in the ICU, and it is in charge of the ICU.
Okay.
So whenever they call, I go and perform the bronchoscopes, and intensivists perform, and if they have problems, they call us, and then we go and perform the bronchoscopes. And fortunately, no deaths. But if you correctly select the patient,
Yes.
usually there will be no deaths.
Yeah.
And if you have the adequate critical care support, there will be no deaths during the procedure. That's definite. And you will
Yeah.
you will see the marked improvement of oxygenation and the
Yeah,
patient
true.
well-being. We get the diagnostics very quickly,
Yeah.
including fungal cultures and the
Yeah.
galactomannan very quickly.
That's true.
So that's a beautiful procedure.
Yeah.
It can save lives and reduce the amount of ICU stay and reduce the amount of intubation as well.
Yeah.
So we should push for this actually.
Yeah.
Yeah, I agree, because correct patient,
select
correct
patients?
time, and with lot of preparation.
How to
Is what
select
is-
patients, that is the most important thing that I have. So this all
I think Madam is having a question.
The microbiologist and pulmonologist are done, yes. This actually, as microbiologist, we can't endorse that as empirical treatment. We can't starting cholesterol as HAP for both HAP and WEP as empiric treatment. And one thing I want to highlight, because starting cholesterol, actually cholesterol is not a very good drug for respiratory infections. The secretion, the penetration is also not very good, cholesterol. And also the one thing I have to mention, because we can't go on like this, because we will, if we start cholesterol as a, so then the next step is that will the organisms will find some mechanism to, so we will get cholesterol resistant. So therefore, one thing I want to highlight here is while we are talking about this the antibiotics, antimicrobials, we have to think of the spreading these infections in the ICUs also, because there are so many now. When we get one person with multi-resistant WAP, so very quickly the other patients also will get sometime. So that part also we need to highlight, and we need to take actions. Infection prevention is very important. Sometimes if you just check your bronchoscope before using the ready-to-use bronchoscopes, sometimes they have multi-resistant organisms, including acinato. So time to time you need to see why your the high prevalence of these multi-resistant organisms in your ICUs. That is also one thing that we need to address.
So
Thank
though
you.
I appears to be a proponent of antibiotic, I am actually a proponent of antibiotic stewardship.
Yeah.
But the problem with antibiotic stewardship is it's prescription of, it's an appropriate prescription of antibiotic,
Yes.
isn't it?
Yeah.
So my question is, my concern when I am seeing a patient who is sick, early warning score of 7 or something like that, who is tachycardic, tachypneic, and then you don't know the microbiology data, that if you, even if you send the microbiology data, it takes 48 hours.
Yeah.
And if you miss the patient and if you reassess, I will be seeing the patient after 24 hours, patient will be managed by the junior doctors, SHOs and house officers in between. If I make a wrong decisions, that would be the end of the patient, as Dr. Mahen said, if I start on the inappropriate. So although so knowing that this is the microbiology profile, so am I justified to not to start colistin on such patient?
Yeah, actually it's now you can just request your microbiologist and others to give you the local data. That is one thing. So according to that you can start, and also you have to think of the severity of the, as you all mentioned, the severity of the, if your patient is hemodynamically unstable in sepsis, of course there is a possibility of starting higher antibiotics. But actually always this web we just encourage de-escalation rather than escalation. That is also there. So I just wanted to mention an additional point regarding this, the prevention of spreading antimicrobial resistance in our ICUs.
So I think key is to always get the expert opinion depending on your hospital where you work, and go for precision medicine depending on taking all the patient factors to consideration and decide antibiotics then and there. I think we had a fruitful discussion with a lot of issues raising up, but that's life, so we have to move forward. So I think this symposium has opened eye-opener for the audience to go forward and do better for the patient. Thank you very much, Dr. Mahen, Dr. Adhavan, and Dr. Amanda for your contribution. And thank you very much.
Thank you, Madam. And to hand out the tokens of appreciations for the speakers, I warmly invite the President of the Sri Lanka College of Microbiologists, Dr. Malika Karunaratne, on stage. Dr. Mahen Kotalavala, Dr. M. Adhavan, and Dr. Amanda Ranavira. I would also like to invite our moderator, Dr. Varuni Samaranayaka, to receive her token of appreciation. Thank you once again to our panel of speakers and Madam Moderator for conducting such a captivating and very intriguing session. And I would especially like to thank our very active audience for their excellent questions and active participation.